So, on to the presentations. We're going to roll through one person at a time, and it gives me great pleasure to welcome our first presenter, Toni King.
Well, I wasn't expecting that. Thank you. So thank you so much for coming into the room and virtually. My name is Toni King. I'm an occupational therapist in adult mental health, soon to be a consultant practitioner. And in my presentation, I'm going to talk you through my journey, which quite literally, don't tell everybody, but began 3 years ago in terms of quality improvement, because although at my interview, I said that I was doing great QI, I actually was on a completely different path and didn't know that there was this other place, this other pathway that we could be using. So I'll take you on a whistle-stop tour of those 3 years. So in the programme, we've been basing a lot of our work around the model for improvement. And I'm going to talk about a few of the placements that I've been on where I've used those QI methodologies and just try in my presentation to show you breadth in terms of place, in terms of people that you might work with or methods, and my colleagues will take us through depth in a moment. So we change placement every 6 months. And here, if we start with defining the aim, which is the first step of the model for improvement, this is an example. If you see the top corner, this is Health Education England, where Sarah, who you'll hear from in a moment, and myself, we're doing a project looking at allied health professionals in advanced practice. And our first step was really to collaborate to understand the problem. So we spoke to 36 AHP leads across the Southeast region. And really, we used the fishbone to try and identify some themes in terms of what the problem was. We used the Pareto to look at which are the most frequent problems. And then we used a driver diagram to try to really recognize the sphere of influence that we could have with only a short 6-month placement in a very complex system. So we found this approach really helpful in getting us down to a quite focused aim, which we felt we could influence and deliver, and we did. Ooh. That's not working. Okay, thank you. Second example, this is from a very early placement where I was on a ward with adults with dementia, and this is using a very simple formula. Staff gave me many examples of things that got in the way of them delivering good practice, and I used this formula to decide between 2 different problems. I learned with QIC Learn how to form a problem statement that had impact that would explain why we were going to look at a particular problem and that it would be accessible to any audience, so not to people within the field, no abbreviations, no jargon. And from there to develop an aim, which for this one was to increase time spent doing enjoyable things alongside necessary things, which in a ward with adults with dementia, there's a lot of necessary things, but there wasn't enough enjoyment going on. I've pressed the wrong thing again. I've just done a little disaster. Now we're just going to get back on the, which, I'm so sorry. Why does... I'm only pressing the cursor. What am I meant to be?
We're back in the right place, I think we are.
Yeah.
Just click there.
Okay, sorry. So second stage is thinking about measures. How will we know that a change is an improvement? So I used several different measures in this placement, which was the one with the adults with dementia, and they were not effective. So I ended up, I looked at mapping spaces, I looked at observation charts, and they were not reliable measures. So I had to review that with the staff. We thought about actually the aim changing to what is the value of these enjoyable things and measuring that. So then what happened in the end is we delivered groups that were for carers and for people that were living on the ward, and we involved the staff. We looked at impact, we looked at their feedback about how they enjoyed it, and we found that this was a much better measure, was to look at value. When I press that, it doesn't there. And I think the value speaks for itself. So images can be data. Second one about measures, this is quick and dirty during COVID, in a crisis team, super busy and needing staff's feedback live because we were working shifts, 24 hours, many changes and needing that information immediately. So the run charts, which many of you would be familiar with, became very important. And another example was with the Academic Health Science Network on the far side there, where we were implementing digital innovation across the region and wanting to simplify the process so that we could increase engagement. So using value stream mapping, we removed the red boxes, which are the no added benefit steps in the chain, and we were able to produce a much more simplified process, saving money, time, and increasing engagement. Let's see if the slide changes. Hey, I've got it. It's okay. So change ideas is the next step. Here's an example where I learned to check with clinicians. This was my first placement. CQC said that in this adult crisis team, the care plans were not written consistently. The manager advised that I look at how to increase written care planning within the electronic care record. And the staff told me that that would have absolutely no impact on the benefit to service users. So by checking with the staff, we were able to change the aim and make sure that we were actually delivering what we wanted. So we combined the two aims and had a multiple approach. So checking change ideas with people is really important. Here, change ideas with service users in a locked, secure unit. This was more of a challenge in terms of leadership, in terms of hearing what these women in the secure unit felt was getting in the way and supporting leaders to hear that and to gather data to explore what was and what wasn't able to be changed. Plan, Do, Study, Act, people will be more familiar with. This is that Academic Health Science Network that we talked about earlier on. For me, learning that the data analysis happens in the do bit was new, I didn't realise, and to map ideas separately. And then this, going back to that first example where we worked with Health Education England, this Plan, Do, Study, Act was in a large webinar asking the audience to carry out the activities and feedback to us in that stage. So this was really us trying to capture a much larger audience in that process. So these examples, I know it's a real whistle stop, but they're all captured in the slides within QIC and the link that we'll give you afterwards. But my key learning ideas that people share when they don't feel that they belong get lost, and ideas when they do belong as part of the solution get used. So that's my key learning.